Hi there, my name is Mike Christian. This is a pre-recorded version of the talk that will be given at the Critical Care Canada Forum later this month. I'm recording this just because it goes into a little more detail and depth into the background and evidence and discussion of the case than I'm able to do in the period of time allotted for the talk, and also for those who are unable to attend the conference in person. So I have no disclosures or conflicts of interest to declare for this talk. So I thought I'd frame this discussion around a case. As we go through, you'll see that there's QR codes whenever there's papers. This QR code will take you to a Google Drive folder with all the references for this talk, so feel free to have a look there, and I'll also put a PDF copy of the talk in there for your reference, so you don't have to try and scribble notes or anything. So this case is based from my time at London's Air Ambulance. I spent about just over 5 years working in London with London's Air Ambulance, as well as one of the regional charities. The system there is an advanced trauma team or advanced critical care team that consists of 2 doctors. One is a senior consultant and a permanent part-time member of the organization. So we have a number of those, and that's one of the roles that I was fulfilling. And then there's a second doctor, and those other doctors are also usually consultants, but they're with the service doing full-time work for 6 months, as is common. They come from all across the UK and all across the world, really, to be able to participate and learn from this service. We also have a paramedic on each team. The paramedics, similarly, there is a small group of experienced permanent part-time or regular part-time paramedics that have previously worked with London's Air Ambulance and have an extensive background in training. And then there's paramedics that are rotating through a 12-month secondment. And they spend their time split between working on the critical care team and then working in dispatch. We also, of course, have pilots for the helicopter and firefighters that support the crew on the helipad. The CERT team responds 24 hours a day by helicopter during the day and by car rapid response vehicle at night or when there's adverse weather. And we deliver services beyond those that are delivered by the typical London's ambulance service, which provides ALS and critical care with their advanced care paramedics. But we also provide, in addition to that, pre-hospital emergency anesthesia, various surgical procedures, of which includes pre-hospital thoracotomy, among others, REBOA, and pre-hospital ECMO, which was initially done as part of the sub-30 trial and is now going into a pilot phase, and this is for pre-hospital cardiac arrest. So this case took place in February of 2021 at just before 3 p.m. At 14:51, a 999 call came in reporting a stabbing. 3 minutes later, the HEMS team was activated, and we launched. Our usual time to be airborne is 4 minutes. Sometimes it takes just a little bit longer if it's a stabbing case, because we have to don PPE and to ensure that we're safe for the scene. We flew to the scene, and the helicopter is primarily to get the team to the scene. We usually go to hospital by ambulance in about 80% of the cases to one of the 4 major trauma centers in London. So in this case, we landed in a park nearby the scene and then jogged to the scene. And the scene was in the outer limits of the territory for our service. It was in southwest aspect of London, in the more the leafy suburbs kind of area. And it's about a 15 to 20 minute drive from the scene by ambulance to the major trauma center, St. George's, which serves that area. This slide is just to highlight that, although I breezed past it a minute ago, that tasking the advanced trauma team in 3 minutes is not something that should be underestimated in terms of how important or complex that is. So trying to identify a needle in a haystack of the somewhere around 6,000 calls that come into London Ambulance Service dispatch every day, the few patients that need and will benefit from an advanced or enhanced care team is really difficult. that is a system that is constantly sort of evolving and still has more work to evolve. But not only that, is it important to then quickly identify these patients, activate the team, and then get the team to the patient in order to have that benefit. So I'll talk a little bit more about this later on in the talk. Just to say that change is probably on the horizon for this area of the response. We've already introduced Good Sam in London, which is video technology, and that's changing how the job is done. And I do see a significant role for AI down the road in helping to support this type of identification. In Denmark and Copenhagen, they're already using AI to help dispatchers identify cardiac arrests, and I think there's opportunities for us to use it to potentially identify the right patients to dispatch an enhanced critical care team for either trauma or medical issues. And also, I think we'll see changes in how dispatch is managed in general, and really splitting between those cases that are time sensitive and those cases which are not time sensitive, and going down much more a route of telemedicine and triage and treatment that way. But that's a different talk. So some of you are probably wondering, well, if the hospital is only 15 or 20 minutes away, why don't we just scoop and run this patient to the hospital? Why are we bothering sending an enhanced care team to this patient? So I just want to walk through that here, and this is one of the areas that I'm taking more time to do in this talk that I won't be able to do in the main talk. So when a stabbing occurs, hopefully shortly after that, bystanders will A, provide some first aid to the person, and B, will call 911 or 999. That call to 911 or 999, although you think it should happen in just seconds, that as soon as someone picks up the phone, a resource is going to be started, that can occur on occasion, but having listened to many of these calls, they're agonizingly long as you sit there waiting for the appropriate information to come out about the address and confirming it and knowing what's going on, and particularly for scenes like stabbings in public, where there's not just one call typically, but there's multiple calls. There's often confusing information coming that's different from caller to caller. Many times people are very upset, and they sometimes don't even know where they are calling from. So for it to take a few minutes, sometimes 2 to 4 minutes for actual confirmation of this location, starting resources, and then specifically notifying an enhanced care team, that's not unusual. So we'll say it takes 3 minutes for this to happen. Once that happens, you have to have the response, and whether that's the police responding or ambulance. We know that in urban centers that traffic is getting worse, especially with all of these measures that are good for public health and bike safety and things, traffic calming, etc., and lower speed limits, but they make it more difficult to get to emergencies when they're happening. And it's not uncommon for a response of 8 minutes, and that's again for police or ambulance to respond. If it's the police, they'll go straight to scene, and then they're going to be initially busy trying to make sure the scene is safe, and that if there's someone with a weapon, that person is contained before they hurt anybody else. And if it's an ambulance response, they're often standing back in an RVP waiting to know that it's safe before they can approach scene. And it's not the first police officer that arrives scene that's going to scoop someone up, throw them in the back of their police car, and rush them to the hospital. You're going to need a few officers to be there before they're able to do that. So that adds to the time on scene, and also bundling someone who's critically ill into the back of a police car, particularly if their peri-arrest is not something that's necessarily easy to do and takes a little bit of time. But assuming that they've been able to do that, and either load them into an ambulance or load them into a police car, then it's going to be the drive to the hospital. And in this case, from that scene, it was about an 18-minute drive on the time of day. Particularly if you have just someone lying in the back of a police car, you can't go understrained. You can't go screaming at high speeds through these streets when you have this critically injured person there, and similarly with an ambulance. So it does take some time to get there, and all those times add up. Once you actually get there, you then have to get the person into the hospital, and particularly if you've done a scoop and run by police, which is much more common in the U.S., there's a whole challenge of getting them out of a police car onto a stretcher and into the emergency department. Many hospitals have started to develop routines for doing this with specific parking areas and procedures, and they practice them, and there needs to be a pre-alert for this to happen. But even with that, you can see that stretcher is not designed for that curb, and getting that patient out of a police car and onto the stretcher and then into the trauma bay is going to take a few minutes. Once they're actually in the trauma bay, then treatment starts. So all that added up is 43 minutes. And that's a pretty slick pre-hospital time. That's without any other the usual challenges that occur, no snowbanks, no elevators to go up to high rises, any of those types of challenges which we often face. Best case scenario, it might be 35 minutes, half an hour. That's even in itself a lightning fast scene time. But if you go back and look at your data quite honestly in your pre-hospital system, I wouldn't be surprised if most of your pre-hospital times from point of injury are about an hour before they ever get to the hospital. So this has been studied extensively in the US. They've looked at the role of police doing this scoop and run, and multiple studies have shown no increased survival benefit. Patients arrive sicker, and there may even be signals of harm. So I think until we actually get the teleporter from Star Trek, it's probably safe to set this aside and say it's not the magic bullet, no pun intended, that's going to dramatically decrease mortality rates of trauma patients in the pre-hospital setting. I also want to just highlight that just because we're not scooping and running doesn't mean we're staying and playing either. So this is London's Air Ambulance penetrating trauma standard operating procedure, and it clearly emphasizes the importance to have scene times as short as possible, particularly if there's no immediate life-threatening procedures necessary. So when I was working, it was usually a very rapid assessment and decision, and I'm about to do a thoracotomy on this patient, or am I not, or REBOA. If I'm not, then we're getting in the ambulance and we're going right now. And I would frequently have scene times less than 5 minutes. And in fact, there's actually a study done in the UK, which looked at this and found that when an enhanced care team was on scene, it actually decreased the scene time and improved triage compliance for patients with penetrating trauma. Right, back to our case. So we arrive scene, we're hands on the patient approximately 15:14. And this is just moments really after the London Ambulance Service paramedics were able to come forward from the RVP. The police officers and armed police that were on scene had already started first aid. They reported to us that this is a male in his 20s who was stabbed in the groin. Apparently he was in a house, and this was done by a female companion. He then ran into the street and collapsed when 999 was called. At this point, he's unconscious, minimally responsive to pain. He's got agonal respirations. His heart rate is 52. He has an ugly, wide, complex rhythm, which looks like acidosis and hyperkalemia and just premorbid. His blood pressure is non-recordable. His oxygen saturations are not picking up, and due to his low flow state. And this is confirmed by his end-tidal CO2, which is also exceptionally low. In short, this gentleman is unfortunately about to die in front of us unless we can immediately stop his bleeding and start to resuscitate him. He's not going to live 15-20 minutes to get to hospital for sure. So this was all due to a result of a left femoral junctional stab wound. His trousers were completely saturated with blood. There was a large pool of blood and clots on the ground. A tourniquet had tried to be placed by the police, but it was ineffective due to the position of the stab wound, how high up it was, and they were doing their best to try and control the bleeding with manual pressure, but that was being ineffective. And this patient is very likely to die. So looking at the data, this is a really good paper that's Bleeding to Death in a Big City that looks at a large trauma system in Texas and all their postmortem cases and identifies where when patients who died of a sanguination died, and over half of them die in the first 60 minutes. So that's why these pre-hospital times are really essential. And if we really want to change the dial and move the dial on these pre-hospital deaths, we have to take new approaches, and it's not just trying to get the patient to the hospital faster, because as I showed you, even in that 30-minute time frame, we're already reaching significant levels of mortality just around then. We also know this situation from our own experience in London. So this is a retrospective cohort of 601 of our pre-hospital thoracotomy cases. And what it tells us is that patients who experience a traumatic cardiac arrest pre-hospitally due to exsanguination have a far worse outcome than those who experience it due to a cardiac tamponade. And I'll talk a little more about this later. So if this patient does go on to arrest, his prognosis, even in front of us, is unfortunately quite dismal. despite the fact that the mortality risk in this case is really high and the odds are stacked against us, we must resist the sense of thinking that, oh, these patients are just going to die anyways. There's increasing data to show that many of these patients die from potentially salvageable injuries. So this study in Miami-Dade, Florida, again, a very robust trauma system, showed that 29% of their pre-hospital patients died, had potentially survivable injuries. These are mostly injuries to their chest and or from hemorrhage, and that novel pre-hospital interventions, they conclude, are required to address these deaths. We can't keep doing the same thing and expect different outcomes. Similarly, a group from Texas, in reviewing 1,848 of their trauma-related deaths, found a similar thing. So they found overall the preventable death rate was 36.2%, and this was across pre-hospital and in-hospital, and that this was double what the predicted preventable death rate was from National Academies of Science methodology. The pre-hospital preventable death rate specifically was 11.5%, and over half of these patients died due to hemorrhage. So back to the case. So within the first 15 minutes of our arrival on scene, in collaboration with the London Ambulance Service paramedics and the Metropolitan Police officers, we removed all the patient's clothes, we conducted our own primary survey, and switched the patient to all of our own monitoring. I inserted the left subclavian trauma line. The other physician, Rob, who was there, inserted a right femoral arterial axis. Then together we inserted a REBOA catheter, deployed the balloon in zone 3, and stopped the bleeding at about 13 minutes after us being there. We then started resuscitating him with plasma and packed cells because we were outside of our, we just finished our whole blood trial and we're waiting to see the results of it. And it's obviously given warmed and under pressure. So just for those who aren't familiar, so REBOA is resuscitative endovascular balloon occlusion of the aorta. And as it says, we put a balloon up through the femoral artery into the aorta into either zone 1 or zone 3, and we blow it up to occlude the blood flow distal to that to help prevent the ongoing exsanguination, and also to aid resuscitation, which I'll talk about more in a minute. Once we've actually stabilized the patient and we have control over bleeding, then we move to something called partial REBOA or P-REBOA, in which we start to partially deflate the balloon. This maintains normal or relative normal blood pressure above the balloon, and then below the balloon we create sort of a regional permissive hypotension. So there's still blood flow to decrease the ischemic impact, but not enough to sort of prevent or cause clot disruption and ongoing hemorrhage. So this is a trace from the monitor in this actual case. So a couple of things. So this trace is from the proximal part of the REBOA catheter, so above the balloon, and this would be in zone 3, so the distal aorta in this case. We do also see a lot of artifact. Unfortunately, the transducers are very sensitive to movement, and unlike in an ICU when someone's lying nice and flat in a bed, often paralyzed, we have a lot more movement in the pre-hospital setting. What this shows us on the far left is that just when the trace started, the systolic blood pressure was just above 50 millimeters of mercury in the aorta. Once we blew up the balloon, we saw an immediate increase in the proximal pressure, and then there's a bit of a dip, which I'll talk about in a minute, and then it continues to progress and increase over the course of the case, and you'll see that we eventually, when we get around 100 systolic, we start to shift to partial REBOA. This is the measurement at the femoral arterial insertion sites. This is after they're below the balloon, and what you see is at this site, the systolic starting blood pressure was just below 50 millimeters of mercury. Once we blow up the balloon, it goes down to less than 0, indicating that we have no distal blood flow and to the balloon or beyond the balloon. There's some artifact in the middle, but it just stays at 0 until we start to move to partial REBOA, where the double hashed lines are there. And after that, we start to see initially a measurable pressure, so showing that we have positive flow, and this continues to progressively increase. And you'll notice that actually it progresses despite the fact that we haven't let any more fluid out of the balloon. And that's because as we resuscitate the person and give them more blood products, volume resuscitate, then we get natural dilatation of the aorta and progression of flow and partial REBOA. We eventually let a little more fluid out of the balloon towards the end of the case as his blood pressure continues to improve. This is a recent paper we published that discusses our more recent approach to how we manage these patients. And in this case, you'd see now that even though he's got a groin injury, because he's peri-arrest, we would now go directly to a zone 1 REBOA as opposed to a zone 3 REBOA. And that's because we've increasingly learned the importance of the diastolic pressures and being able to get good coronary perfusion to help abate the cardiomyopathy that's developing in these patients and to help resuscitate them more quickly. So once we do that and we go into zone 1, blow the balloon up, once we've resuscitated them, started to volume resuscitate them, and we're getting evidence of stability, then we'll do one of two things, either potentially reposition down to a zone 3 and or go to partial REBOA. But this article has a lot more details in terms of our approach. Just going back to this timeline we mentioned earlier, I said at the 43-minute mark, once the patient gets into the trauma bay, that's when treatment starts. But that doesn't mean that you immediately get hemorrhage control in this patient or that they're stabilized. And that often takes more time. And depending on where you're actually going to be able to undertake that hemorrhage control, whether it's you're able to do REBOA in the emergency department or whether the patient has to go to IR or OR for hemorrhage control, that's going to delay when you actually get substantial control. And again, I'd suggest you go back and really with a critical eye look at your time to hemorrhage control from the point of injury in all of your cases. And the data would suggest that in experience, even in some of the most highly fine-tuned hospitals, is that can take upwards of 60 minutes or longer to get a patient, OR open patient to the OR and achieve hemorrhage control. What we're doing by taking a little bit of this team to the scene is actually moving that to the left and managing to stop the bleeding and obtain that hemorrhage control within 37 minutes. So saving a substantial amount of time. This is exactly what John Holcomb found in the research that he was doing and what he's been proposing. He actually says the peak time to death after severe truncal injury from hemorrhage is 30 minutes. And that you can see why even the best scoop and run is not going to enable patients to get to hospital likely in that amount of time. His review of large data sets and the literature and his own institution, which again is a highly well-oiled trauma service, it takes about on average 2.1 hours to achieve definitive truncal hemorrhage control in a patient from the time of injury. And so that's 128 minutes if it's done in the OR. He proposes, and why he's advocating for this, that if you move some of these techniques to the emergency department, you'll decrease that time by 57%, but it's still 55 minutes. And what he advocates is what's being done in London and elsewhere is really the need to move it to the pre-hospital setting to achieve that under 30-minute time, which is a 78% decrease in the time. And even in our case, it wasn't ideal. We were 37 minutes, so 9 minutes over his ideal target for when we should be able to achieve that. Just a comment for a minute about rural and remote settings, because a lot of the data I'm presenting is in urban settings. That does not mean this is not applicable in rural and remote settings. If anything, it's more applicable. So we know that the rates of death from trauma in these areas are far higher. We know the time to get to any type of definitive control is a lot longer. So the ability to move that hemorrhage control and advanced procedures to the patient rather than the patient to those procedures will dramatically decrease the time to which that's achieved and the potential benefit that the patients can receive. And there's a greater opportunity to decrease mortality. It's also not just about sending a retrieval team, an advanced team. It's about how do you mobilize a whole system and look to see which providers are available in the area that might be able to be involved. And what we see in many systems across the UK and Australia and other parts of the world is how they can actually get local physicians, emergency physicians, GPs, intensivists, etc., to support the ambulance service on a sort of a case-by-case basis with proper training and equipment to get out there and help these patients. And here in Canada, in Vancouver, there's a unique system in North America with North Shore Rescue, where they have doctors and nurses that go out with the search and rescue team to be able to provide advanced care. This is commonplace across search and rescue in the UK. In Australia, the South Australia government has a program called the Rural Emergency Response Network, which gets physicians out supporting the ambulance service there and providing some of these advanced measures until the retrieval teams can get there. And then similarly in Scotland and across the UK, there's BASICS, which is the British Association of Immediate Care. And again, they get physicians out to be able to provide care to these patients until the HEMS teams can arrive. This is another paper from the review of coroners and medical examiners deaths in Texas, and this was 300 patients over a year in 2017, and they found that 12% of their trauma deaths were potentially preventable. These are pre-hospital trauma deaths and amenable to advanced resuscitation interventions. So these are the ones that where something they feel targeted intervention can be done, and they discuss in their conclusions the need for a system of pre-hospital physicians to be able to enable operationalizing these types of advanced interventions. It may be possible to consider other providers they discuss, but I'll talk a little bit later about the issues in terms of feasibility of really enabling that. Prior to departing scene, we continued our hemostatic resuscitation, including packaging in a warming blanket. As his systolic blood pressure started to increase, he began to experience some discomfort and pain, so we judiciously gave some sedation and analgesia, but his blood pressure, as I pointed out earlier, didn't tolerate this. Despite his blood pressure dropping, he began to wake up, and as we were wheeling him towards the ambulance, he tried to sit up and was quite agitated. So this necessitated a rapid RSI to facilitate both his safe care and transport to hospital, as well as his ongoing management when he arrived there. En route to hospital by ambulance, we continued the resuscitation, transitioned to partial REBOA, as I mentioned earlier, and gave him calcium. So in terms of what happened at the hospital, quite early on scene, we declared a code red, which activates a major hemorrhage protocol in the region, and so the hospital can start to prepare to receive this patient. We also sent in a REBOA pre-alert, so they knew that we were bringing in someone with a REBOA. When we got to St. George's, we did a walk through the emerge, so that's literally a walkthrough. That gives us the opportunity to, with the patient, so we can pick up additional blood products if necessary, and if required, we could always do a pit stop there and do any immediate stabilizations. But the plan was to go direct to the theater, which is the hybrid theater, unfortunately on the second floor of St. George's, so there's a bit of a precarious elevator ride, hence the reason to have that second sober thought when you're going through emerge. But we took them straight to the theater. There we did a handover to the trauma surgeon and trauma team leader. However, despite handing over the care and doing the clinical handover, the HEMS team remains and continues to manage the REBOA to try and cognitively offload the team and allow them to focus on other priorities until we think there's a safe period to transition the REBOA to the other to the receiving team. In this case, before we handed over, they'd placed a pneumatic tourniquet and asked us to deflate the balloon to see if we had hemorrhage control, but unfortunately the bleeding continued. The pneumatic tourniquet wasn't able to effectively stem the bleeding, so the REBOA was reinflated until we could have direct vascular control obtained. And luckily, as we hoped for, this patient did very well, so he was discharged from ICU 24 hours later, despite coming in obviously quite initially shocked. He was discharged home 5 days after the stabbing, which is remarkable for someone who was literally moments away from dying, and he had no significant complications from his REBOA. So this is thankfully not an uncommon case in terms of the successes in London's Air Ambulance, and now we'll talk a little bit more about the other broader benefits. So looking at this from the perspective of the quintuple aim, so impact on patient outcomes, financial sustainability, staff experience and well-being, patient experience, and then health equity. I'm not going to be able to cover all these in depth, even in this extended talk, but I am going to start to dive into a few of them. So we'll start first with the most common reported outcomes, which are around saving lives and quality of life measures. So These are two studies, both in the Netherlands, that try to quantify the impact that these type of services have. And these are HEM services, so they're physician-led helicopter emergency medical teams, but they don't always respond by helicopter. They respond by both helicopter and land, and they don't also always go back to the hospital by helicopter, just like in London. They often go by land. So this is not these aren't evaluations of helicopter as a mode of transport versus ground. They're truly evaluations of physician-based critical care pre-hospitally versus standard of care, which in the Netherlands is advanced life support and by highly educated paramedics who have university degrees and are very experienced. So it's not sort of a BLS marginal standard of care. This is excellent care that they're receiving in the standard as well. So for adults, they showed an additional 5.4 lives saved per every 100 adult patients treated, and in the pediatric population, it was 2.5 additional lives per every 100 pediatric patients. Probably one of the most robust analyses in terms of the clinical impact of an advanced or enhanced critical care team on a system was that which was done recently by the Welsh Emergency Medical Retrieval and Transfer Service. So given the data structure in Wales, where they have a single data center that gets data from all sources, including health and social services and other government agencies, and they have a single identifier for these patients, they're really able to do a detailed analysis of the impact of this service. And this is a service that came in, there was a pre-existing air ambulance that was paramedic only staffed, and then they brought in a physician-paramedic, actually physician retrieval practitioner, which is sort of an enhanced level of paramedic model of care. And after the 5 years of doing this, they found that 30-day mortality for blunt trauma patients decreased by 37% across the system. And that was a statistically significant with an odds ratio of 0.63. So I'll speak more about this study a little bit later on. In terms of another example, this isn't a comparison, but this is just some data from our 601 pre-hospital thoracotomy cases. And these are all patients that were in traumatic cardiac arrest or peri-arrest in the pre-hospital setting, unlikely to have survived to hospital, unlikely to have even gone to hospital in many systems. We had a 1 in 20 survival to discharge rate for these patients. That's 30 additional lives that were saved from these. Not as high as we'd like it to be, but certainly having met a few of these patients who have had exceptionally good outcomes, it is remarkable to see someone who was dead on scene from a knife wound to the heart be able to be living a healthy and productive life afterwards. 76% of them have a good neurologic outcome. If their arrest was due to cardiac tamponade, there's a 25% 1 in 4 chance of surviving. And if they arrested in front of the HEMS crew, their chance of survival increases to 46.2%. We recently conducted a meta-analysis from the literature looking at studies which compared physician-led enhanced care teams that were targetedly deployed in interprofessional teams compared to standard ambulance response, which again was in almost all cases, except for one in France, advanced life support delivered by exceptionally well-trained and university-educated, usually paramedics from countries around the world. In terms of the studies that looked at mortality as the primary outcome, we see that there was a significant decrease in mortality that favored the physician-based care with a odds ratio of 0.08. Now, for those studies that looked at survival as their key outcome, there are many more of those who were able to subdivide them into trauma cases and cardiac arrest. And the trauma cases, again, a odds ratio of 1.39 of increased survival favoring the physician-based interprofessional teams. And for out-of-hospital cardiac arrest, similarly, a 1.52 odds ratio. And these are all statistically significant. And just to highlight that this isn't just about trauma, There's a role for these enhanced critical care teams for having an impact on medical patients as well. And I'm told or read that the latest draft guidelines of the ILCOR guidelines actually now will be recommending pre-hospital critical care teams around the world, typically delivered by physician and paramedic interprofessional teams, as part of the management of recommended management of both adult and pediatric cardiac arrest patients. In terms of quality of care, in Scotland, they introduced this Scottish Emergency Medical Retrieval Service over a decade ago now, and the first year of their expanded service, they undertook a robust evaluation of the impact of the service before it was fully funded. And in that year, they did 222 retrievals, most of which were inter-facility. A small number were scene calls. And then in addition, but not included in terms of the quality calculations, they also provide telemedicine advice to the country. So overall, they found a range of just about 0.5 to 3.5 qualities, additional qualities per patient that was treated. Over the course of that year, that adds up to between 104 and 777 additional quality adjusted life years gained by the population of these patients that were treated, which is truly remarkable for a service just in its startup phase, but speaks to the impact in terms of not only does it save lives, but it's also saves lives with good quality. Moving on to the financial side, because I'm sure all of you are thinking this is great, but how much does this possibly cost? There's some really interesting data around this as well. So again, going back to that Scottish assessment, they identified the cost per quality being between 1,500 and 11,000 pounds per additional quality saved, which sounds like a lot, but but NICE uses a guideline of 20 to 30,000 pounds per additional quality as representing good value for money. So this service falls well within the a reasonable range for value for money, according to the NICE assessment. When we think about value is driven by outcome and quality over cost. And I've just shown you that these physician-based pre-hospital teams increase the outcomes and the quality of care. But you're thinking, oh, it must increase the cost. And actually, that's not necessarily the case. So there is evidence that I'll show you in a minute that actually shows that costs of this type of system can be even decreased compared to the cost of trying to deliver critical care, pre-hospital critical care, and other approaches. As part of the strategic case analysis for my MBA, I undertook an evaluation of different models of pre-hospital and retrieval medicine teams. The analysis, which included a financial effectiveness analysis, showed that the inclusion of physicians, both as a part of a hybrid approach and as the core members of the team, was the most favored in the analysis, weighing in all the various factors. One of the reasons for this is because many people don't realize the cost of training a critical care paramedic is approximately $300,000 for each CCP, and then there is a significant annual cost for maintenance of skills, whereas if you look at physicians, it's quite a minimal cost for their initial training. You just have to teach them some basic skills to be safe in the pre-hospital setting. They have all the clinical skills necessary, and there's no ongoing cost really for skills maintenance because they do that in the hospital. And further, if you employ a model such as in London, where you use seconded fellows who rotate through, then you have a cost which is actually less for one of these fellows than it is for a typical critical care paramedic salary. Of course, the medical oversight, clinical governance, and medical supervision required is constant for all the different types of clinicians. A lot of the paramedics, when they hear this, start to worry that this is about replacing paramedics, and it's most certainly not. This is some small targeted teams. So like for an example, in London, that's 1 or 2 teams for 10 million population, and about 8,000 to 9,000 paramedics. And the other thing they worry about is that this is like a zero-sum game, whereas if you add a physician into the mix and bring their skill set, that the skill set of paramedics is going to decrease and you'll need less skilled paramedics. And again, the evidence does in no way supports that as being the case. In fact, if you look around the world, particularly in the UK, Australia, Scandinavia, what we see is that they actually both raise the bar for each other. So that the synergy of a physician-paramedic interprofessional team delivers skills at a level higher than either of the individuals would by themselves, but also really raises the bar in terms of the development and having a high-performance team where both professions push the envelope and excel. And in many of these areas, you have some of the highest trained and qualified paramedics that are working with physician partners on these services. And this is just one example. This is evidenced by the system in the UK, and this is from over a decade ago when this was in place and started. In Canada, it's just a concept at the present time of having these expanded scopes of practice rules for paramedics and the higher levels of training and education. And you'll see both in the UK, Scandinavia, Australia again, that where they actually have interprofessional teams of physicians, nurses, paramedics, OT, PT, others, all working together in the pre-hospital setting, that paramedics actually advance further and faster as a profession in those areas than they do in areas where they operate in isolation and not as part of interprofessional teams. Finally, moving on to one of the last areas, so staff experience and well-being. And this, the data is starting to grow in this area, but there's impacts on recruitment and retention, which I'll talk about some evidence in a minute. The ability for these types of teams, particularly physician and retrieval practitioner-based teams, to go into centers and do coaching and mentoring with the staff that's already there. It's very beneficial for those staff. There's decreased moral distress both for frontline first responders, which we know we have significant issues with in the paramedic profession, but having senior clinicians and enhanced teams that are able to come and back you up when you have the sickest patient you may see in your career is definitely something that can be protective. But also for staff that are working in rural and remote areas, to know that the cavalry is coming and someone's there to be able to help, and your patient's going to get timely and effective care is also very reassuring and gives them the confidence and the willingness to work in some of these very difficult and then isolated settings. And finally, there's a whole capacity building across the system component to this. So just a little bit of the data. So again, back to Wales from their 5-year service evaluation. So the presence of this service recruited 12 new additional consultants into Wales, which have been hard to fill positions. There are 32 part-time consultants who, so about a third of the consultants were new of the 32 consultants that are working in the system, and they work part-time in the system and part-time on the retrieval service. This system, having access to it, also recruited 55 fellows to hard-to-fill posts across rural areas of Wales. And so what they do is they offer these fellows an opportunity to 20% of the time or 1 day a week to fly out and work on the air ambulance or with the enhanced care team to develop more experience and often prepare for a secondment opportunity somewhere. And this opportunity makes people, because it's combined with the posting for the rural position, very attractive to people. And the fact that they had these fellows in those positions, which were otherwise either unstaffed or were because they couldn't fill them, or were backfilled with locum and agency coverage, ended up saving the health authorities £2.75 million from having these positions filled with fellows. It also attracted a very high caliber of fellows to these roles, and there's evidence that they were then transitioned into consultant positions. They were retained and stayed once they'd had the experience of those communities. So this is a big benefit for these communities. Also, there was significant teaching done. So in the Wales thing, so 100 CPD events with a significant amount of this training going to the ambulance service. As I said, building capacity and raising that bar, advancing skills, with over 600 Welsh ambulance staff trained through these various events. And this is not unique to Wales. It's done across most of these advanced systems, and even here at home, the STARS Academy is an excellent example of how this can build capacity in communities across a region. Finally, just talking about health equity, again, the Wales analysis specifically looked at health equity as one of their measures for outcome, and their aim was to reduce the number of emergency inter-hospital transfers by 30% with the service. They actually decreased it by 41%. So that means that patients are going to the right place the first time, as opposed to having to be an interfacility transfer, which often ends up being done by local staff and has that knock-on effect on the local staff. The other thing is that there was improved access to pre-hospital critical care. So after introduction to the service, they doubled the number of attendances of physicians at these critical events, which meant more advanced interventions were being given. And then and then specifically measuring the actual interventions, 42% of patients bypass the local hospital to be taken directly to specialist care. So that decreased the impact on the smaller hospitals and all the patients that were there, but also we know that the secondary transfers are associated with a significant increase in mortality. So this was better for those patients, and they received critical interventions faster than they otherwise did prior to the introduction of this service. So a few closing thoughts. One is just as Mark Twain said, there is no such thing as a new idea. And just to really emphasize for people that, this idea of pre-hospital critical care dates back to the origins of the definitions of critical care. And Peter Safar, who's one of the heroes and one of the people I certainly looked up to, included in the definition, point 3, that intensive care, including all components of emergency and critical care medicine delivery system, pre-hospital and beyond, was included in that original definition. And I think we've forgotten about that, and we need to get back to including that in our practice of critical care. Just hats off to nods to a few people in the country. So Orange has just hired, here in Ontario, has just hired their first 4 flight physicians, and the team in Toronto with the First 60 program is starting to do some really interesting research and focusing on this critical time. And I'm sure we'll be coming up with some amazing advances. Similarly, STARS regularly uses flight physicians in both Saskatchewan and Manitoba, to a degree in Alberta, but hopefully that's increasing even more and will eventually become routine in Alberta as well. Just to my colleagues who are on this call, so Dan, who's the paramedic on the left, and Rob on the right of the shot on the left, it was actually Rob's last call in his last shift. He did this. He eventually came back to us as one of the consultants, and Dan has been a regularly returning emeritus paramedic who's been with London HEMS for over a decade. So these are my final contact details. Thank you for taking the time to listen to this presentation, and I'm happy to answer any questions if you email me.